Hello, and welcome to the Lancet Pulse. I'm Matthew Gilbert, the North American Clinical Acquisition and Outreach Editor based in New York.
And I'm Jonathan Pym. I'm one of the senior medical editors based in London.
And we're here today to discuss psychedelic-assisted therapy with Dr. Rachel Yehuda from the Icahn School of Medicine at Mount Sinai and Dr. Liliana Galindo from the University of Cambridge.
Yes, but before we just get into introducing them, Matt, maybe we should think a little bit more about the use of psychedelics over the last, 200 years?
At least.
Are you able to give us a potted history of where you think we've come with psychedelics then, Matt, since you've had a look at it?
Quite a long way. Cultures around the world have been using different forms of psychedelics for therapeutic and ritualistic purposes for thousands or tens of thousands of years. And of course, in the 1960s, the Western medical establishment took notice following the work of Drs. Timothy Leary and Albert Hofmann. But before too long, these drugs became so associated with the countercultural movements of the 1960s and 70s that they quickly found themselves made illegal around the world. And any and all research into their potential therapeutic uses stopped until the last 2 decades when they've experienced a renaissance of therapeutic potential and investigation.
To help us on this psychedelic journey, we've got 2 experts.
Hi, I'm Rachel Yehuda. As you said, I'm from the Icahn School of Medicine at Mount Sinai, where I direct a psychedelic research program called the Parsons Research Center for Psychedelic Healing, and also run a psychedelic research center at the Bronx VA.
So my name is Liliana Galindo. I'm a consultant psychiatrist by background. I am based in Cambridge in the CPFT NHS Trust, where I work as a clinician, and also assistant professor at the University of Cambridge, where I lead the Cambridge Psychedelic Research Group.
Excellent. Well, thank you again, both for lending us your expertise and experience. So psychedelics have been used for thousands of years. In the last decade or two, there's been a great resurgence and rediscovery of the therapeutic aspects of many of these drugs. If I might ask each of you, Drs. Galindo and Yehuda, if you could please briefly describe what you think makes the current field of research different than prior investigations and the kind of traditional history of the Western medical establishment is embracing psychedelics.
What's different now? Well, a lot of things are different now. I think that there's a very big mental health crisis and not a lot of answers for what people with mental health symptoms can do to heal. And so every possibility needs to be explored, and psychedelics offers a really important new avenue for exploration. At the same time, there's a lot of investment by industry in developing psychedelic compounds, in testing ones that we've already known about, and bringing them to the approval of agencies like the FDA in the US and other regulatory bodies around the world. So that investment is also means that the medical field is starting to take these compounds seriously. And I think that a lot of people seeking their own kind of healing have experimented with psychedelics and have really brought that to the attention of the public. And their advocacy for the helpful nature of these potential therapies, I think, has also really caused a different kind of discourse.
Interesting. And while in the U.S. we hear quite a lot about the anticipation of the gold rush to commercialize and maximize the reach of these therapies, I understand that the situation is quite different in the UK and Europe, where the regulatory field is not quite as optimistic.
I have to say that I feel optimistic, although I understand that it might be a different pathway than in the US. As you know, in the UK, we have the NHS, that is our public health service. And it's a moment where actually we need to think how will be the way to embed properly psychedelic therapies in a public health system, right? How are we going to train our therapists, our medics? How are we able to get actually approval to be potentially to get these treatments to be nice approval and to be able to deliver? It's an exciting moment because there was a big investment in what's called the mental health mission in the UK. And as part of this, there was the creation of many mood disorder clinics across the country. In these clinics, there are clinics that are designed to be able to integrate clinical and research interventions, is where potentially the future, it might be the right place to foster and somehow these treatments. I think that there is a lot of happening in the UK. I think that many clinicians like myself are standing up to say, okay, we want to advocate to these therapies and we want to make sure that they are available for the people who need it the most. So I understand that, yes, the pathway might not see as clear, but I think that, or at least from my perspective, I might be a pathological optimistic, but I see many options for the UK.
Regarding the optimism in the regulatory environment, at least here in the US, much of that seems to be bolstered by the mountain of, or rather growing physical evidence that can more concretely link the pharmacological effects to the psychological changes. Regarding clinical work, have any of these more discovery science oriented advances produced meaningful biomarkers or imaging tests that may be relevant to the practice of therapy or patient selection, adverse events, contraindications, things like that, that might be more practical to the day-to-day work of helping?
I mean, the development of biomarkers just in general has been aspirational, and we haven't quite succeeded in using biomarkers in mental health the way that they're used in medical conditions. But we're trying as a field, and as the number of psychedelic clinical trials grows, I think most people who are involved in this kind of clinical work are using some kind of a biomarker add-on so that they can track things, even if it's as simple as wearables or heart rate or blood pressure or physiology. Our trials definitely involve taking blood samples so that we can look at things like epigenetic changes and hormonal changes. And we do brain imaging also before and after the entire therapy so that we can look at potential stable changes in the brain. But it's going to take a while for the field to get the data that it needs in order to really kind of live out the dream of the potential of how biomarkers would help us. But for now, I would say that we don't need biomarkers to tell us who to treat and who not to treat. More than other approaches, psychedelics seem to target a wider range of responders. So in that sense, we could say with great confidence, based on the trials that have been published to date, that more often than not, there will be therapeutic benefit, which is not what you can say for all other existing psychiatric treatments, I think.
Absolutely. And Dr. Galindo, have you had a similar experience?
Yes, I fully agree. I think that the topic is really interesting and is how we can translate what we know about the mechanisms of psychedelics and the reality that we still have a lot of research to do to really understand the underlying mechanism, to be able to translate in actual psychological outcomes, right? We have, or until now, what the evidence tell us is that there are clear changes in brain activity. We know that, for example, there are clear changes in what we call the default mode network, that potentially this is something that will be translated in reduction of rumination, reduction of those rigid beliefs that we have about ourselves, all those rigid narratives that, as we know, are present in many different mental health challenges, including depression, anxiety, but also others, including OCD, eating disorders, addictions. And we know that in that case, in somehow what psychedelics are bringing is the opportunity to somehow reshape all those rigid cognitions, all those somehow to relearn those patterns in our cognitions, in our emotions, that potentially will allow to new ones. As we were mentioning, clearly it looks like neuroplasticity. is playing an important role as an underlying mechanism. And that is why we always speak about a window that possibly happened during the day and the day after, and some days after the psychedelic treatment, where we need to take the opportunity to somehow integrate. So this comes to something really important. Again, we are speaking of not only giving a psychedelic itself, we are speaking about giving a psychedelic in a clear setting, and hopefully with sessions where the person can be prepared to get the psychedelic experience. Of course, sessions when they are receiving the treatment, but they will be well supported by a trained therapist, but also they will have other type of sessions where they are able to integrate those experiences and take opportunity of that window. There is a lot of research that we need to do to understand specifically which component will be the best for which specific type of patient. My hope is in the future, hopefully we'll have so many tools, so we will decide which component will be the best. But I fully agree. I think that we are seeing that these molecules has a therapeutic potential across several different mental health challenges.
How do you explain to your patients how the actual psychedelics work? Because I've always got patients coming to me saying to me, my serotonin's low. And is it that these drugs are boosting your serotonin or your dopamine or your glutamate?
Well, I wouldn't say we're glutamate, dopamine, serotonin. I wouldn't bring that part up. I would say these drugs are heart openers. They're going to help you get in touch with your narrative, the things that you've kept shut behind closed doors. They're going to make you be less rough on yourself, less judgmental, less ashamed to really talk about the things that you think are your deep, dark secrets. They're going to give you a different perspective. You're going to go on some sort of a journey that we cannot predict in advance, but that will take you probably to places that you've never gone before in your mind and maybe even in your body. And we will be there with you the whole time to keep you safe and grounded. And then we'll just talk about it a lot if you want to during the session. And certainly we'll have a lot of sessions afterwards where we can pick up on the material. What enables the psychedelics to be so powerful is that they do, in a very interesting way, allow people to form more interpersonal trust with themselves and their therapists, and somehow reduce the fear that people have when they start thinking about past memories. For a lot of people that have been traumatized, when they think about what happened in the past, it's like it's happening now in terms of their physiology. And their strategy has been, let's not go there, let's not open that door, especially if the traumatic event does involve something that you feel really bad about, which many traumas do. A lot of people second guess how they reacted or what happened or why it happened and all those kinds of things. And there's just a lot of feelings. So what the psychedelic is designed to do is really open you up so that we can start talking about some of these things. And you might see things in a completely different way that will be healing and will give you kind of a mandate to move forward.
So when you are talking to your patients, you don't really talk about the neurochemistry. What do you think, though, is actually happening in the brain? And what would you say to people at that stage?
Yeah, I don't think I would want to talk about that as the first thing. I would want to talk about why that matters to you so much, what's happening in your brain, when the real issue is what's going on in your life. And, most people are suffering not because of their serotonin levels, but because of their relationships with other people. With the fact that they can't feel a full range of emotions like love, and anger is an emotion that they overfeel or fear. And so I would, as a neuroscientist, I'm enormously interested in those things. But I think that bringing that conversation in right now to patient care or to research participants, which is how most people get their care right now. I'm not sure why it is relevant to people who are suffering, except that it's a proxy for, is this safe? What's this going to do to my neurochemistry? You know, I would try to get under the question. Like, what is your idea about what that means to tinker around with your serotonin or with your dopamine or with your receptors? Because that must have some meaning to you. So I wouldn't discuss it neuroscientist to neuroscientist. I would try to really try to get under the question.
Liliana, what do you say to your patients when they're considering having their treatment?
Well, I have to say that I'm based in Cambridge. That is basically a university surrounded by a city, but it's pretty much many of the patients and the people are also academics. So actually many people ask me about the receptors and neuroplasticity and neuroimaging. So many times I do have this conversation. I fully agree that yes, there is a part of the models that we have, because again, we still need a lot of research to try to understand how psychedelics really work. And of course, we have conversations about how they act in the serotonin pathway, but also how glutamate could have a role in the plasticity. But what I usually use actually in the way to explain them, I really like the analogy of thinking in psychedelic assisted therapy almost as a surgery, right? So in a surgery, when there is a wound, you are using an anesthetic that creates some changes in the pain threshold, and during a period of hours, that will give the opportunity to work and somehow to open the wound, to clean it, to see how you can and somehow repair the wound. And then there is a period after the surgery where the person continue the healing and needs to probably do some exercise and a process to recover from that. But it's the person who does the healing. And the way how I see it is that psychedelics are again also changing the way our emotions, how our thoughts work, our pain threshold, our emotional pain threshold for a period of hours that allows the surgeon, but primarily the person, and here is where is the biggest difference in a surgery. We see that the surgeon is somebody external, almost in psychedelic assisted therapy. The one who is leading is the person, is the patient, right? The therapist is there to support as a co-pilot, but the first surgeon is the patient. And then there will be a process of healing that continues after the session. And then somehow what we are aiming is to have a really, as any surgery, really intense intervention, but with the hope of be able to treat the core and recover. And I think that definitely is, or at least what I want to usually transmit in the clinic, and it represents the change of rather than focus on treating the symptoms, is less treat the core behind the symptoms.
Might we now turn to the actual different agents that people are using, the different psychedelics, and discuss which ones are used for the different disorders that we see in patients?
Sure. So right now, unless you count ketamine as a psychedelic, there really aren't too many psychedelics or any approved in the United States for specific indications. They're legal in some spots and people are using them. But right now, we don't have specific indication of using psychedelic X for mental health condition Y, but they're being studied for depression, for post-traumatic stress disorder, for addiction, for eating disorders, for OCD, anxiety, end of life. I mean, lots of different things. And so what that should tell you is that there's something about the psychedelic therapy approach that is what we call transdiagnostic, that it doesn't have to do with the diagnosis that you've actually been given. It functions on a different level, which is very refreshing for me to hear, because these categories are a little bit artificial to begin with, because most people have features of many different things at once. And so there's something about doing this kind of work that really, it doesn't matter what diagnosis you've been given, and that's nice. Now, in terms of what different agents will be better suited for different diagnoses, I think that it's more the question of which kind of agent will be suited for the work that a particular patient wants to do. So with MDMA, for example, there's a lot of therapy that usually goes with it, or that's currently the recommendation. For LSD, for example, the latest study on anxiety said, well, you don't really even need the therapy, which I wonder about, but, take it at face value. So that's going to be very interesting to sort out. Some psychedelics will have longer medication sessions. The effects might last up to 8 hours or even longer. But some psychedelics may give you a very brief psychedelic experience. And again, it's not just the drug that you take, it's the context in which you take it. There's a before giving the drug, there's a during, and there's an after. And a lot of times we focus just on the drug and not even on the during, but just on the drug itself. But the psychedelic therapy is embedded in a larger context. It takes weeks and months. It's not hours or days. And that's really important for people to understand. But what you're doing during the time that the drug isn't in your system is really thinking about what happened when it was. And it brings up a lot of material. I mean, people who have taken drugs like psilocybin or MDMA or LSD consider the first time they took the drug one of the 5 or 10 most meaningful experiences they've ever had in their lives. It really is, like being given a telescope or a microscope to your brain or your consciousness or your soul or spirit or something like that. And really being able to kind of see things from a different perspective and see where you fit in to the world and where others fit into you. And so for many people, they want to talk about that. They need to talk about it. They should talk about it for a long time, because the idea of having an insight is to use it to galvanize change, to change the things in your life that haven't been working. And maybe there's been a reason for that, your traumas, your addictions, your depression. But somehow you are given marching orders that, wait a minute, I've got to change it, and I have the power to change it. I may need to access a few resources to change it, but this isn't going to. That's why I answered the question about serotonin the way I did, because we have the idea that, we'll just tinker with a little bit of this and that in the brain, and everything that ails us will be taken care of, because it's a chemical thing. Having a chemical counterpart doesn't mean that it's a chemical thing. And I think where we've gone wrong in psychiatry is that we have had an overly reductive model that suggests that it is like diabetes. Give some insulin, it's going to be fine. But even in diabetes, it's not that simple. There's a whole lot that you want to understand about health factors and risk factors and management and your relationship to diabetes and risk factors. It isn't just about insulin. So it's really, and that is really how we have to start approaching mental health. And it's not just about the individual. It's about their family and their community and their society. And it's all these different levels. And so the idea that it's just been a patient in an office with a provider and a faulty wire somewhere is really something we have to get away from. And even though I'm a neuroscientist and should be speaking this language fluently, which I guess I could if I wanted to, I just don't think it's a helpful language for the human soul.
So, Liliana, if I could just ask you just a little bit, perhaps, how the trials are conducted. Do you actually have a specific manual, for example? And then once you've explained how you do the trials, is it possible for you to say what disorders are being treated and with what agents you're using?
So the reality is that at the moment there is no an established or there is no consensus about which specific therapy. What we know is that each clinical trial in somehow propose a different manual. I think that again it's a really exciting moment in the field because as well as we are starting to study many components, also we are starting to study different psychological approaches to pair in somehow with the psychedelic. I'm aware that at the moment there are several studies across the world that are trying to combine different modalities. And again, I really hope that in the future, hopefully we will have a large range of tools. The one that we use the most is what we call inner directed therapy. That means that rather than having a therapist who is constantly directing or somehow asking or intervening, and somehow the role of the therapist is to be there to support the person that is the person who is leading the journey, the process, right? And again, in this type of experiences, the way how everyone has such a profound experiences and how complex this could be is something that even for the therapy that is there, they are only getting a glimpse. So actually, when we intervene, we might be in somehow affecting the full experience, right? So in somehow that is why a model where actually the therapist, yes, is there to support, is there to connect, is there to feel that empathy, that container, but is the person who is leading. Now, commenting in the other point, I think that also I have to say I really feel thankful to be able to be part of this field in this moment, because what we are seeing is that right now we have so many clinical trials for many different components. And as Rachel was mentioning, we are really seeing that one component actually could have a therapeutical effect in many different mental health challenges. So, and that finding is so important that us as psychiatrists, we're starting to rethink maybe we shouldn't have such a rigid categories about mental health challenges, because at the end, what we have is a person in front that could have anxiety, depression, an eating disorder, maybe in the past had an addiction. So we cannot just divide them in somehow in different categories. What we know is that, for example, for depression, the one that until now has been studied the most initially was the ketamine. And of course, at this point, we already had the phase 3 trials with psilocybin, and that is showing a clear improvement in sustainable improvements for depression and for treatment-resistant depression. Currently, there is the beginning of the phase 3 trials also for 5-MeO-DMT that is also showing many promising results. In the case of PTSD, definitely the one that has the most evidence is MDMA, that as we know, we already had the phase 2 and phase 3 trials. And there are many others interesting findings. So in the case of psilocybin, also they already show very promising results in phase 2 trials, and now they are going to start the phase 3 trials. In the case of anxiety, as Rachel mentioned, we know that in the case of LSD, but also other components like DMT, and they are also starting to do even phase 2 for psilocybin. One of the ones that in somehow for me are more exciting as a psychiatrist is for all those mental health challenges that actually our current model really don't have effective treatments, or treatments that at least unfortunately only a minority of the patients respond, like is the case of OCD or anorexia. And in both cases, actually, there are already interesting pilots that have shown that psilocybin could have important therapeutic potential. And for this, I am really excited to, and I hope that larger clinical trials will come. And in the case of addictions, also we have seen many initial pilots with psilocybin, with ayahuasca, with iboga. At the moment, there are several trials, even with dependence, that are really severe, like is it the case of amphetamine use or even opioid dependence, and they are responding and also sustaining abstinence even after 3 months of being treated with only 2 sessions of psilocybin. So again, it's interesting because the same molecule could have an important therapeutical effect in different conditions.
Thank you very much indeed, Liliana. That's very interesting. Can we now go to Dr. Yehuda? And I'm not wanting to any way pin you down, but can you be more specific about where we are with the trials and specifically with what agents you're using and what disorders you're trying to treat?
They're in process. I think there might be a completed trial for depression for compass pathways. They just started. They're thinking about PTSD now also. But Resilient Pharmaceuticals have already done 2 phase 3 trials for MDMA-assisted therapy for PTSD. So again, it's going to be a tight race to see whether psilocybin for depression gets approved first or whether MDMA-assisted therapy for PTSD gets approved first. But they're kind of neck and neck, and it will be very interesting to see. And after that, I think that's going to really lubricate the pipeline quite a bit. And then we're going to be able to also see a lot of new research coming and maybe the development of new compounds. So it looks like this, in the next few years, we're going to see rapid investment and development in this, and hopefully rescheduling at some point. Once a psychedelic is approved by the FDA, there's really not a good rationale to keep the schedule to be a Schedule 1, which is what it is now, which means that the drug has potential for abuse, which has never really been that demonstrated, but more importantly, has no potential medical benefits. So once it's approved, that part's not true for sure. And once you reschedule psychedelics, then really clinical trials become easier to do, and doctors have more flexibility if they want to prescribe a Schedule 3 compound, even if there's no indication. And that is going to be the beginning of really having real world data on what it's like when patient asks for these therapies. Of course, with that, we're going to have to make sure that we can train therapists, can receive the right education. We have to educate the public also about what it really means to have a therapy with psychedelics. But I think we're getting very close. I think there's a lot of people that are interested in the question of psychedelic plus what else. And I really want to emphasize how important it is that this isn't just another drug. Again, that is what got us into this mess of needing a new paradigm for mental health. And so just kind of doing more of the same with the same philosophy and the same mentality, I think will limit the potential here. And again, people do report good outcomes even without formal psychotherapy, but you don't really know. It's unmeasured what they're really getting with a guide, what they're getting before, what they're getting after. But you can have this great experience that is very profound. But the question is, what do you look like a year later? How did you take that experience and make a meaningful change in your life that makes your life better and makes you better, makes you feel better, makes you better able to live in a meaningful way? So the cautionary note, the thing that keeps me up at night, is that the molecules will really drive the conversation when they're just a part of the conversation. And the non-drug factors are equally important here. And again, psychiatry started out with psychotherapy, needing a little help with pharmacotherapy. And now in most mental health settings, a different person gives you a drug and gives you therapy. They're really very divergent areas. And so hopefully now we can kind of come together with an approach that allows people to really talk about the things that they need to talk about.
It seems to me that we are getting away from the actual scientific or neurotransmitter understanding of the approach. We are moving into a much more holistic way. I find it difficult, though, Dr. Yehuda. You're clearly a neuroscientist, but you seem to be looking at it in a much more anthropological, almost sort of sociological way. What do you think about that?
So I'm not a clinician, so I know I sound like one, but I'm a neuroscientist that really began to understand the limits of neuroscience. And I have had clinical administrative roles where I've really seen that patients need a lot of things, sometimes a lot more than they get from just being given medications or just even being given psychotherapy alone. What's been really missing from our discourse is really how community and society and family have to be part of the healing process. And yeah, I come to it from neuroscience. This might be a little unusual, but look, I mean, you can't deny that this is bigger than that. Anybody with eyes can see that people who just go to therapy, but who have terrible environments at home, or who don't have the support systems of their family, or don't have anybody to love them, don't do as well, even if they do everything right in therapy and they're with the greatest therapist on earth. There has to be meaning in your life. There has to be attention to your heart, to your spirit, to your mind, to your body, to the whole thing, to your health. It's all one big connected thing. And so I would like to see mental health treatment and approaches really broaden themselves outside of a psychiatrist's office or a therapist's office to really include well-minded approaches where not everyone even has access to a mental health provider, which is also very challenging for the psychedelic field, because I don't think the therapist isn't doing anything when they're sitting in the room and letting the patient drive. I think the therapist is doing a lot. And what they have to learn how to do is really understand the orienting principles that allow them to flexibly make real-time decisions without relying on a predetermined agenda, which is sometimes what we do with our cognitive behavioral approaches that have been helpful, but usually when the problems are very circumscribed. And so I think therapists do a lot of interventions. And what I have found is that our outcomes are terrific because our therapists are so terrific. And each session is different. And each session reached into a different part of the therapist's expertise. So it is an opportunity for therapists to really learn to work with people in a different way. And the question of the future of who will be able to administer psychedelics is a really important question. What kind of training, what kind of credentials? But hopefully we'll be able to have a team approach here where, there's a role for a lot of different players, including peers and including non-licensed people, to really do what it takes. It takes a village here. And that whole village has been absent from a lot of people's care. The absence of a village itself is part of the problem. And you cannot solve that with molecules alone. We have to just use this as a mandate for a different way of attacking people's psychological wounds.
Very interesting. And if I might follow up on that, just as we wrap up here, considering that so much of our conversation has centered around how personal these experiences are and how the molecules themselves are transdiagnostic, and as you just said, it takes a village. both of you envisage future where regulatory approval is accompanied by a kind of standardized therapeutic manual, or do you think psychotherapy is best left at the discretion of the therapist administering the drug? How do you see this being kind of taught to future clinicians once they're past the regulatory and clinical hurdles?
So what I would predict is that, again, we are just at the beginning, that we are exploring probably different therapies coupling with different molecules. My hope is that in the future, we will have enough evidence to have a large range of different tools, and realistically, rather than trying to apply the same manual to every patient, ideally, what we need to do in the clinic is to think how we can tailor the intervention to adapt to this person rather than adapting the person to the protocol, right? And here is where is the important translation, that we need to make the step that we, at the moment, we are, yes, using the protocols because the way to have access to these treatments is through research, but in the future, in the clinic, we need to change the way how we are operating and tailor our interventions. The second part, and here I think that is where is really our challenge and our opportunity. We need to think how we can work better to prioritize the patient. I am a firm believer in public health. I'm in the UK, where, well, fortunately, we have a public health system. And what we really need to think is making sure that this is something that will not stay in private clinics. Psychedelic-assisted therapy shouldn't be only for the people that can pay. Psychedelic-assisted therapy is an effective treatment that should be available for the people who need the most. And actually, if we follow that track, the reality is that, and as Rachel was mentioning in the moment, we are in a mental health crisis. There is no enough staff to actually treat as many people as we need. So actually, I think that the next step, and this is something that in my group we're also focusing, is in group therapy. We think that if we want to escalate and we want to actually bring this to more people, we need to think in rather than individual interventions. The big question is, can we provide this treatment by groups? Actually, what if by group and taking advantage precisely of that empathy and that openness and how these treatments help us to connect with others might even actually enhance the treatment, the outcomes? Can we create also in that group that peer support that would allow the process after the clinical intervention? Well, there are many questions. So if you ask me, I think that I hope that we will have many treatment modalities rather than a manual, a rigid manual.
And maybe help to build a little village for those that don't have their own. And Rachel, yeah, if you might close this out.
I'll close you out. I think ultimately people will freelance and apply their own kinds of therapeutic approaches once they have a lot of experience here. But in the beginning, I think that we do want to have pretty precise guidelines. And we've just gotten our treatment manual that we've been working on accepted for publication. It'll be available online soon for MDMA. It's called IMAP. And it's an integrative model for MDMA-assisted therapy, inner-directed, but really gives the therapist a lot of guidelines because it's embedded within a framework of both psychedelic work and trauma work. Look, you had a surgery analogy before. This isn't another knife that we are being available in a catalog and saying to the surgeon, well, you know what to do. This knife's better. This isn't that at all. You do have to say, hey, you know what? There's a different approach here, especially since the psychotherapy field has been predominantly very directed with cognitive behavioral approaches. We have to say, I know that you've been taught to do first psychoeducation and then, give people a very focused way of going forward. Let's talk about how you use all your knowledge in a different kind of way where you're flexibly reacting to material that is spontaneous, nonlinear, and can really move very rapidly between kind of a euphoric state and a very distressed state. I think that we will need to do a lot of education and training. And I want to really give the message to providers out there that it's okay if you feel a little nervous about working with compounds that put people in an altered state whose trajectory cannot be predicted. You should. That's a good sign. A more worrisome side would be, what could happen? I'll just see what comes and rely on my clinical wisdom. I mean, what we want to be able to do is give people very concrete guidelines for the do's and don'ts of how to work with someone in an altered state, and trust them, and trust their training and education and their ability to learn from experience. We want both of those things to happen. So I'd like to, in the beginning, hope that there will be very explicit guidance for how to work with patients in an altered state. And I'd also like to see comparative trials, approaches where you use the same molecule, but perhaps different psychological supports, and you really compare one against the other. We're doing a ketamine study where we're giving ketamine the regular way with an infusion and no psychotherapy versus ketamine-assisted psychotherapy, which is really using the ketamine very much like a psychedelic and employing the kind of psychotherapeutic model that you would similarly employ with psychedelic therapies. And we're going to compare one against the other. I think a lot of people have feelings about what might work and what should be done. And I believe cognitive behavioral approaches should be tested with psychedelics. But until they are, and until we understand really what it looks like, we won't know. And we should just keep a sense of humility about the fact that there's a lot for us to learn, but we shouldn't be scared also of these compounds. I think the biggest training to give is don't be afraid of what happens in an altered state. And I think that a lot of people are afraid of what might come when somebody is in an altered state. And that is why we also have a protocol for training therapists by giving them MDMA within a very controlled therapeutic setting so that they can see what this is like. And so all of these things are hopefully things that the future may bring. I want to take this really seriously because it's such an opportunity for badly needed change.
Well, thank you very much, both of you, for joining us. I feel like we could talk for another hour easily, at least. However, we're pushing the limits of our episode capacity at the moment. But Jonathan, do you have any other questions or?
No, I think that's amazing. I'm a bit blown away by the whole thing. It wasn't what I was expecting here. We've gone from a very biological approach to now an extremely sort of psychodynamic, almost psychotherapeutic one, which I've found enlightening and interesting.
Yeah, very enlightening. And not the usual stuff that we get to read in our capacity as editors. That's always more molecule focused and hard outcomes, et cetera. So this was, yes, a very refreshing conversation. Thank you again. If we get the opportunity, we'd love to have you back for a sequel episode. I know some of those regulatory approval or decisions are expected in the first half of this year. So things are looking bright, and hopefully we'll continue to get brighter.
Thanks for listening to the Lancet Pulse. If you enjoyed this show, leave a rating or a review on your favorite platform and subscribe to stay updated on our latest episode. The editorial team includes Chloe Wilson, Ben Abbott, Matthew Gilbert, and Jonathan Pym. This show is part of the Lancet Group podcast offering, and it's produced by Matteo Simonetti. Thank you for being with us.